Thank you all for being here. Thank you, Dr. Niarco. It is a great pleasure to work with Dr. Niarco, I have to say. Um, and we are very happy to welcome our first keynote speaker, Arjune Sen, coming all the way from University of Oxford. He's going to be talking with us about public health. I couldn't even begin to give a picture of his expertise. It's in the program, the PDF that's been sent out. I'm just going to invite him up and not take any more of his time, but let him teach us something. So.
Thank you very much, Phil. Thank you, Dr. Niarco. That's a wonderful opening remarks, actually, which I entirely endorse and agree with. And we will talk to some of that during the course of this talk. It's important to also thank Gabriella, who kindly invited me to this meeting, to Phil and Jen for all of the logistics that have helped, and to all of you for being here on a Saturday morning. I'm very impressed, actually, both by the lecture theatre, because you have individual chairs that you can sort of mobilize and adjust, that you have PowerPoints within the desks, and that you're all here on a Saturday morning. None of these things happen in Oxford. You know, it's just benches, and you'd be lucky to get people there on a Saturday. But it's wonderful to be here. So I'm going to talk about AI equity in an inequitable world. And this opening slide, I thought I would keep it because not just because the algorithm said this was a good slide, but it really demonstrates that whatever anybody says, we live in a highly interconnected world. And we all have our part to play within that world, and it's important that we do that. But the world we live in is highly inequitable. Many of you will be familiar with this picture, which is the front cover of Time magazine in 2019. And it was the opening part of a project called Unequal Scenes. It's taken in Johannesburg, South Africa. And you can see separated by a highway that there is gross disparity between two suburbs within Johannesburg. And the statement on the cover was the world's most inequitable or unequal country. And the project has taken forth. So this is actually also in South Africa. This is in Durban. So my wife and her family are from Durban. This is in the Philippines, and this is in Mumbai. So we live in a highly inequitable world, and it's important that we acknowledge that. And this also applies in Baltimore. So Unequal Scenes has also taken photographs in Baltimore, and you can see that highly gentrified neighborhoods and refurbished apartments and flats can sit exactly across the street from more difficult locations. You will also all be familiar with this graphic. This is again taken from a long time ago, showing the difference between equality and equity. And equality is providing the same resource for whoever it is in society. But not everyone needs the same resource. Sometimes you need to give more resource to certain populations, and that relates to equity. Also from this slide was reality, and we might feel that that is particularly the case at the moment, that actually marginalized and less advantaged communities really have far less opportunity, but what we're obviously looking for is liberation, where there are no barriers and everyone has clear access, whether that be to healthcare, which is what we're going to focus on in this talk, or other elements in society. I looked at this slide again, though, and one of the things that I don't quite understand is why, as well as liberation from barriers, the gentleman has also been liberated from the bottom half of his trousers. So he does seem to have acquired a bit more hair, though. Now, in looking at equity and equality, it's not necessarily what you think. And that's also important to highlight. So we might have thought with the COVID-19 pandemic, this enormous thing that ravaged humanity, that we would actually come together and we would be better as a society after the pandemic. That does not necessarily seem to be the case, but this was an interesting finding from a study that we set up. We set up COVID and epilepsy study group during the pandemic. And especially during the first 2 years of the pandemic, what we did is track the impact of the pandemic on people with epilepsy, carers of people with epilepsy, and healthcare workers who mainly looked after people with epilepsy. And you can see on the left-hand side that it's a large number of responses that were captured from a wide variety of countries across a wide range of time points. And towards the end of last year, we published the final part of the study, which was looking at things globally. So how had COVID affected people with epilepsy and their carers globally, comparing people who lived in high-income settings, such as the US, such as Europe, such as the UK, compared to people in the rest of the world. So that would include low to middle income countries, but also upper income countries, upper middle income countries as well. Now, all of you who have submitted papers or who will look forward to submitting papers can get quite concerned about the reviews that come back, and reviewers are always asking you to do more and more things. But actually, this panel came from a suggestion from a reviewer because they asked us to look at what had happened to ethnic minorities in high-income countries compared to everyone else. And what you can see in this panel here, so you can see a comparison between high-income countries, non-high-income countries. And if you look at the top panel, it's whether you've been infected with COVID-19 or not. And actually, it's fairly similar. So across the time frame, if you were in a high-income country or a non-high-income country, rates of COVID were pretty similar. What about the difficulty in getting help for your epilepsy during the pandemic? And that's the middle panel. And what that shows is that if you were in a high-income country, so if you were in a high-income country and you came from an ethnic minority, you had significantly more difficulty getting help than if you were from the indigenous population, if you were in a high-income country. But if you're in a non-high-income country, it was the same. So the disparity is in the high-income country, not where you'd necessarily expect in places where there's less resource. So a high-income country, from an ethnic minority, you had more difficulty getting help for your epilepsy. And in the bottom panel, you also had a bigger impact on your health, regardless of whether you had the infection or not. So you might think, well, maybe if we really thought about it, this would be expected. But it just shows that there is enormous disparity in high-income countries as well, because for the ethnic minorities in those high-income countries, actually care was worse than if you were in a low-income country where care was equal. It may not have been the same standard as the high-income country, but it was equally distributed through society. So I thought what we would do is look at inequity through the lens of epilepsy. And so I work a lot in epilepsy, and that's the basis of my clinical practice as well. But epilepsy is a good condition in which to map equity. And then we'll look at why, I'm not here to transform all of you into epileptologists. We'll look at why epilepsy is a good condition as examples for studies of inequity in mind-brain health. So first things are that epilepsy is very common. So 50 million people have epilepsy worldwide, 85% of whom live in low resource settings. There's increased risk in lower socioeconomic groups in high income settings as well. It's a condition that associates with significant risk of injury, including head injuries, risk of mortality. So that can associate with burns or drowning, but also from the seizures themselves. It associates with key comorbidities, so it has a very big impact on cognitive well-being, psychological well-being, psychosocial well-being, and it definitely represents more than seizures. And you can see the global incidence of epilepsy played out there on the map, and you can see the regions such as Latin America, and parts of Africa where the incidence is extremely high. Now, what is epilepsy? So hopefully this is all of you, and I love this slide because I created it a long time ago. This is meant to represent all of you. The cogs are whirring, information is settling. But the reason I love this slide is my daughters have never managed to work out how I did it. The problem is that now I can't remember how I did it either. But anyway, so this is the brain network. So the network is working. And then what happens in epilepsy is you get a disruption to the network. So the cogs don't quite align anymore, and epilepsy should be viewed as a network disorder. Epilepsy, though, itself is not an equitable disorder. So we've heard already that it's more common in low to middle income countries. It's also more common in older populations. And populations are aging worldwide, but they're not aging equally. Populations are aging 3 times more quickly in Africa than they are in places like America and the United Kingdom, for example. Similarly, in far Southeast Asia. And if you have a condition like epilepsy, where the prevalence and the incidence is much higher in older populations, then the condition is going to become much more common. So epilepsy is already very common, but it's going to become more common because populations are aging and it is more common in the older population. But even that doesn't play out equitably. So this is now looking at epilepsy, incidence of epilepsy, so new onset epilepsy, in Medicare beneficiaries within the United States. And you can see there that it becomes much more common as we get older across all ethnicities. So that's the green bar. So if you're over 85, that's when the incidence is highest. But if you are Black, then the incidence is higher still. And particularly if you're a Black male, then that's when the incidence rate is particularly high. So we have this condition that's very common. It affects people from low to middle income countries. It's much more prevalent there. It's going to get more common because populations are aging. But in that population aging, it's not going to affect people equally. It will disaggregate out according to ethnicity. It's also a condition where there are lots and lots of treatments available. So these are just some of the treatments that are available for epilepsy. And as you can see, it is skyrocketing the number of treatments that are available. And there are new treatments. So this is what treatments that are available in the United States, not available in the UK very much at the moment, where you can use laser treatment to try and treat the focus where seizures are coming from. So it's a highly treatable condition. So to pull all of that together, common condition, going to get more common, affecting certain groups disproportionately, but there are treatments available. So what are the barriers then? This is something we should be able to solve. Well, there are huge barriers. And one of the big barriers is stigma. And stigma can play out in lots and lots of different ways. So throughout time, epilepsy has been stigmatized. It's been associated with thoughts that epilepsy and seizures may relate to possession or lunacy or retribution, or it may be contagious. And even though it's described in Babylonian texts, and again, there's no need for anyone to interpret that, but it is described in Babylonian texts, it was always, and for a long time, and perhaps still, considered something that is not within the medical framework. So Hippocrates had to write that with this disorder, epilepsy, which was called the sacred disease, he wrote, "It appears to me to be no wise more divine nor more sacred than any other diseases, but has a natural cause like other affections. So it should be treated like any other condition, but it isn't." So Julius Caesar had epilepsy, and at the time of Julius Caesar, one of the treatments for epilepsy was gladiator blood. So these are gladiators in the arena there. And what would happen is people would stand with small clay bowls outside the walkway to the Colosseum. And when people had been, like whoever had been killed in the Colosseum, you would stand with those small clay pots, you'd try and gather the gladiator blood. You would then take the gladiator blood home to your relative or friend who had epilepsy, give the gladiator blood, and seizures stop anyway. So the fact that you gave the gladiator blood, it wasn't the gladiator blood that caused the seizure to stop. The seizure was going to stop, but you create an association that gladiator blood is a cure for epilepsy. So we have to unpick all of that. Why is this relevant to an AI conference? You know, why are we talking in an AI conference about gladiator blood and Julius Caesar? Because myths can persist and data is critical. Data are critical. So if the data are not correct, because it's just an association, it's not causation or correlation, you're not going to get good data out of your AI model. To emphasize stigma even more, this is how one of participants in Kenya described her seizures. So she said, when I fall down, those people are aware, like yourself, when I have fallen, you will see me. But for me, when I fall down, I see a figure, not a person like you or me. It's the devil, that one. You see him clearly. So you can imagine if someone is describing their condition in this way, that can lead to a lot of stigma related to epilepsy. And there can be stigma directly and indirectly. There can be stigma because there's a preference to go and see traditional healers. And this poster was put up in a workplace. One of our patients in Oxford, she had a seizure at work. She was off work for about 10 days. She had about 4 days in hospital. When she went back, these posters were everywhere around her workplace. And so indirectly, she was being discriminated against because everyone knew it was her that had been off work. And that proved very difficult. The second difficulty, and this relates again to how we're going to implement AI, is infrastructure. Infrastructure is not equitable worldwide. And I thought it was important at this point to have a little bit of audience participation. So it's not an exam, obviously, but what I'd like you to do is just think about, and if you're brave enough, write down, and if you're really brave, I might ask you to say, how many neurologists you think there are in the following locations. So the United Kingdom has a population of 68 million. How many neurologists, roughly? New York City has a population of 8.25 million. How many neurologists, roughly? And the Democratic Republic of Congo has a population of 105 million people. How many neurologists, roughly? I'll pause for a moment because some people are writing things down. Does anyone want to guess? Is anyone willing to guess? Yes, please.
All right, United Kingdom, 350. New York City, 70. Democratic Republic of Congo, 2, maybe 3 if it's maybe separate.
Okay, all right, okay. Anyone else? We'll take one more guess if anyone else is brave enough. Otherwise, that's a very good yes. Okay, all right. Yeah, it may have been set up that way, just possibly. Yeah. So these are the numbers. Yeah. The United Kingdom has 1,000 neurologists, so roughly 1 per 68,000 population. New York City, just down the road, has 2,677 neurologists. That's 1 neurologist per 3,000 people. Yeah. And they have more psychiatrists, but that may be something about New York anyway. So by contrast, DRC has 10. So that's basically 1 neurologist per 10 million people. So you're going to have to be mindful of this if you put in new technology. Like, how are you going to embed it? And how is it going to work differently in New York compared to DRC? To illustrate that a little bit more graphically, this is a photo again from some time ago of a proportion, maybe a third of the neurologists that were practicing at that time in the United Kingdom. And at the same time, this is my first trip to Zimbabwe. This is a photo of all of the neurologists in Zimbabwe at that time. And as you can see, one of them is me. So when I arrive in Zimbabwe, I double the number of neurologists. When I leave, it halves. Zimbabwe population is 16.5 million people. And we also said that epilepsy is a highly treatable condition. So you have medications that really work, but there can be a lack of availability, there can be a lack of accessibility, and a lack of affordability. And I didn't put it in this presentation, but there's a treatment for Alzheimer's disease called aducanumab, which was developed, and it seemed to be the next great hope for Alzheimer's disease. And the cost per quality adjusted life year for aducanumab was shown to be nearly $1 million. The total healthcare spend in Zimbabwe per capita every year is $50. Aducanumab is not going to therefore be able to solve Alzheimer's disease in populations where we've just said are aging much more quickly and conditions such as Alzheimer's disease are going to become much more common. So these are the challenges. So epilepsy, very common, 85% in resource-limited settings. There are lots of barriers, stigma, lack of knowledge, lack of treatment seeking, lack of infrastructure, lack of clinicians, lack of diagnosis, lack of medication. And sometimes that can seem completely overwhelming, just like a wave coming over you. But this is a photo of the nephew of a very close friend of ours. His name is Ian. So that's not AI generated. That's not me. That's Ian, and he's one of the world champions in giant wave surfing. But the reason we showed those two photos together is if Ian can do that on waves, we can do that in healthcare and the kind of things we do. We can't become giant world surfers, but we can do things in our areas of expertise. And so this is the moniker for our group: to think big, start small, but you have to start. You're going to have to start. So how do you start? Well, the first thing to think about, and this underpins all of the work that we're doing, is to actually learn and understand. So Einstein said that any fool can know. The point is to understand. So if you're going to understand a condition, you're going to have to get into communities and really understand the problems that they're facing. So we have this video that we put out. So how can the future be better for people with epilepsy? We've transformed that into the future can be better for people with epilepsy. How do we get there?
So sorry. Sorry for our online audience. We were not video sharing, so I'm so sorry about that. We want people to see.
Okay, hopefully you won't lose participants now that they can see me.
And don't forget, you do have a clicker here.
Oh, thank you. Okay, thank you both very much. So not how can the future be better, the future can be better, how do we get there? So one of the things is about learning. And again, I would advocate that this underpins all of the AI work that you're doing, is there has to be actually an ethnographic understanding of the condition and how it affects local communities. So we do this through an oral history work stream. So understanding the local perceptions, incorporating that lived experience, and understanding approaches to diagnosis and treatment. So oral histories aren't just about the person and their life experience with the condition, but you can begin to understand barriers to diagnosis and treatment, and also understand how they might integrate and incorporate AI-driven technology into their communities, into their health systems and their health structure. So this is when we started. So this is myself and Sloan Mahone, who's a professor of history in Oxford. And these are some of the areas that we discussed in community groups. And we've been doing that work ever since, so for the last 7 years. And we've acquired about 400 oral histories, and we're putting that into an oral history repository. And then what's going to happen is you can then run models over that and pull out various themes. So let's say you wanted to look at impact of epilepsy in marriage, for example. You might be able to pull out that theme and try and really understand what is going on in communities. The second thing you need to do is you need to empower local populations. So this was a survey done, the African Youth Survey in 22, about whether people thought their country was going in the right direction or not. And you really want your country to be going in the right direction if you're going to stay. But so you do need to train more people, but you need to decide who you're going to train, how you're going to train them, and where will people stay once they are trained. Of course, these aspects about is my country heading in the right direction don't just apply to low to middle income countries. But therefore, if we put all of that together, there are huge opportunities. So how can we try and avail ourselves of the opportunities that do exist? So again, to challenge potential misperceptions, education and literacy can be extremely high in low resource settings. People really want to learn, they stay at school, education can be exceptional in places. There may not be many healthcare clinicians in terms of doctors, but there is a vast network of primary healthcare workers who can go into the field and will help deliver care. And the tech is much, much better than you think. So when we first went to Zimbabwe, the only people who were paying in dollars at the supermarket were myself and Sloan. Everyone else was already paying with their mobile phone. Why? Because if the banking system doesn't work, you want security of your money. So it's better that it's on the phone than in the bank. It's better to just pay that small transaction fee. So already, way before things like Apple Pay had taken off in the UK, everyone was using mobile wallets. So how do we harness this? Because we do live in this data-driven world. So firstly, can we make new tech? Can we get better tech? And can we get that to primary healthcare workers? And one of the things we've done is look at apps to try and help diagnose epilepsy. So we developed a diagnostic aid, which was published in Lancet Digital Health, and now a bit of AI. So there is some AI behind this and how we did it. So we had a very large data set. And exactly as you were hearing from Professor Kofi, you need good data in and you need culturally contextualized data. So this is an African data set where about 5,000 people, multiple data points, you put all of that in and you have a group of clinicians who agree a final diagnosis for that population. You can see there on the left what we did. So we created a model training set and an internal validation data set followed by an external validation set, which was acquired more prospectively. And we looked to try and see what were the number of features you needed to identify before the curve started to asymptote out. So where did the model continue to improve? And you can see that about 8 features were enough. After that, really, you didn't get much more gain, because what we wanted to do was create an app whereby primary healthcare workers could ask binary questions, yes, no, and screen people for convulsive epilepsy. A variety of models were used. You can see their logistic regression, support vector model, and so on and so forth. In the end, we decided to go for the logistic regression model, both in terms of efficacy and ease. So using that, then you can see the area under the curve, figure 4 there. The area under the curve to predict convulsive epilepsy is very good. And it was validated both on the internal validation set and the external validation set. Importantly, we also presented this work at a conference a couple of years ago, which was on AI and epilepsy, and that won the Best Poster Award. Why am I putting that up there? Not to show off at all, but just that actually winning poster awards matters. So do vote when you're asked to vote for the poster awards, yeah? Okay, but so that's all very well. But we also heard in the introduction that you have to make sure if you're going to have these technologies and you're going to deploy them widely, they have to be appropriate to the communities you're going to deploy them in. If you have a chest X-ray, a chest radiograph algorithm that doesn't work for people from ethnic minorities and doesn't work for women, have you really got a diagnostic algorithm? So next step, what we did is we looked at the sites. So again, these are the sites listed here, and we tested the model on internal validation data and external validation data. You can see internal is green. And if you just look at Agincourt, for example, the model works extremely well on the internal data. The data from Agincourt model is good to predict convulsive epilepsy, but much less good at external validation. And that doesn't apply universally. Sometimes actually it's the other way around. And there's going to be a trade-off between where you have like a really narrow model that's really built on the data from that specific area and how you try and apply that more broadly. We looked at that in another way as well. And so this is looking at various thresholds. Again, you can see the sites there and just testing the model. Again, it's all about the model to see how well the model works on its own data set and how well it works on external data sets. Because there's a trade-off point whereby you can say, all right, well, this is very good on the internal data set and it is good enough on the external data set, but you're going to need to contextualize the external data set as well. You need new data. And what we really argued for in this paper is that it's critical that you don't just create an app. Let's say you create an app in Kenya, and then you say, fine, we've got an app for convulsive epilepsy in Kenya. That's going to work just as well in Argentina. It won't. You need data from Argentina to inform your app for Argentinian people with epilepsy. So we then put all of that together and created so that from the data and the weightings and the study, we put that together into an app. And this is the app. This goes quite quickly. But basically what you can see is this is given to primary healthcare workers in the field. It's for people over the age of 6. They enter the data and you can go very fast. It's into a variety of local languages now. And it can also be because you can have the app and the healthcare worker doesn't necessarily even need to speak the language that the person with epilepsy is answering the questions in. So, but you can see yes, no, and you work your way through a binary set of questions. And once you come to the end, there are 2 sets to these questions. Once you come to the end, what the app will do is give you a prediction in the back end of how likely it is that this person has epilepsy. So you can take your data sets now from Africa. You know that you have to make sure that they're contextualized for the local communities, but you can use this then as a screening tool to say, well, who are the people that actually need to get to those very few neurologists that exist? So it's not, the idea isn't to replace the neurologist, it's just to get the right person to the right place. And you can see here that it says referral needed. There is a percentage that comes out, but we don't show that at the moment to the primary healthcare workers because we're still doing validation for it. But it's designed to streamline the process of referral. And as you can see, sensitivity and specificity are good. So this is what we're trying to do with the technology and the data sets, is to get people from the rural communities, the right person to the right doctor in the right time. We've now expanded out beyond convulsive epilepsy. So convulsive epilepsy is where the body goes stiff and shakes, to other things that may not be epilepsy or look like, but they may look like epilepsy. So so-termed dissociative seizures. And we've also broadened it out to other types of epilepsy. And this is the work that is ongoing at the moment across Africa and a little bit in Brazil as well. Just give you a rough idea of the number of screenings that have been done and the number of assessments that have been completed, and there are new countries that are coming on board all the time. Okay, that's all good, but what else can we do to try and really help? And so one of the other things we do is look at hardware design. So these are EEG headsets. So EEGs are when you put electrodes onto the scalp and you record brainwave activity. And they can help in the diagnosis of epilepsy, but not just epilepsy. They can also help, for example, in people with Alzheimer's disease. So it's much more broadly applicable than just epilepsy. The prototype that we started on 4 or 5 years ago now, as you can see, has changed dramatically to the new prototype. But that cultural contextual understanding, that oral history, that lived experience was critical in getting from prototype 1 to prototype 4. There's a very basic thing with prototype 1. When we took that out to the field, people told us no one will wear this because it's white. And the white color is very off-putting, and people will feel that it's a shroud being put over them. So you have a stigmatizing condition like epilepsy, you're putting a shroud on them, no one will go for that. So now all of the designs are in black. When it was initially put on, people thought that actually, instead of recording brainwave activity, it would insert things into the skull, into the brain rather. And so we had to do some work to try and demystify those aspects also. So working with your communities is going to be critical to developing any new technology. And then hopefully this will play. It may or may not play with sound, but this is just to show how the headset works. So conventionally, to do an EEG recording, if you did an EEG recording in Oxford to get the electrodes on, takes about 25, 30 minutes, something like that. And then this is just playing in real time. Maybe the sound won't work, so I'll just talk through it. So you can create a model for the head. You can then take the headset. You put the headset onto the head. You can see the various bands that are there. And the electrodes are embedded within the bands. You then take the headset, put the headset onto the head. You take an Allen key, just as you would do to build your flat pack furniture. You tighten the headset. That creates the contacts of the electrodes all over the scalp. And you're done. So now the electrodes are up and running. Then it shows the wires all run through the headset. These will be embedded within the frame. It transmits via Bluetooth to a tablet. This is the gearing mechanism that underpins all of this to create make sure that the electrode configuration stays the same. And then this is the 3D printer that prints it all. So what we're now doing is taking the 3D printers and just installing those into different countries. So you don't now need to transport the device at all. You just send the code and print it locally, and then you can deploy it at scale. So what does this do? Well, it allows us to make non-specialists more specialist, because you now have the EEG headset and you have the app. So you can use the EEG to try and stratify people and get them into care appropriately. And this is the algorithm. This is where a lot of work is currently going. So these are somewhat older data now. Because if you have the EEG and the EEG creates a record, you need an algorithm to read the EEG, because the EEG is just a wave, it's mathematically modelable, if modelable is a word, but you can model a wave. And so then you can use that to, again, streamline who needs to get to the neurologist and who might need to go to a cardiologist or elsewhere, depending on what the cause of the attack may be. And so this is the ecosystem that we're looking to now create. So it's always culturally contextualized tech at scale. That's what we're trying to do. So a person may see a primary healthcare worker, they go through the questions on the app, they put the EEG on, they get a recording. The EEG also is analyzed with an algorithm. All of that metadata comes through to the cloud. It sits in Oxford at the moment, but it is shared with all of the individual sites. And that then facilitates people to get to the right doctor in the right time. And this is just summarizing that in terms of the pathway. So possible seizure, get an accurate history, do appropriate investigation. That's what we would do in the UK. But what we're building in is the cultural specific understanding, capturing data in an app. We're working with partners to create a video platform so that people can upload videos of the events as well. We build in the headset, and then we get into an integrated diagnostic platform. And then the appropriate person will go to the appropriate doctor. That's the aim. But the same principle can apply to any other condition. It's not, this isn't to say epilepsy is the be-all and end-all. It is just using the same principles to underlie other conditions. So examples is we're planning on starting some work with a colleague who's creating a database of psychosis, first episode psychosis in Asia. So we'll be working with them to deliver the same principle as we did with the epilepsy app. And this is a way of looking at Alzheimer's disease using technology. So here, this is an app that was developed by the Oxford Cognitive Group. You want to be able to test memory very easily and very quickly, but you don't want what's called practice effect. So practice effect is if you do a memory test today and you do it again in a week's time, then you'll probably remember a certain amount that you just did today. If you do a memory test today, you do it tomorrow, you'll remember a lot more. So you need something that there isn't practice effect on. So what this memory test does is it looks very specifically at hippocampal function. You show two fractals, screen then goes blank. You then show different two fractals, one of which was on the first panel. And what you have to do is identify which of the two fractals you saw before. So most people can do that. But then you ask the participant to drag the fractal that they saw to where they saw it. So not just what you saw and where you saw it. And people find that much more difficult. And there can't be any practice effect on it because it could have been anywhere on the screen. How are you going to learn? You can't learn that. It is just a test of memory. So this is the way you can kind of build in tech that is completely language agnostic. There's no language behind it. It doesn't matter whether you speak Hindi or Portuguese or English. It's the same test, and you don't have practice effect. So if you're going to really build all of that together, you might have seen that the acronyms for the different areas, the different steps all spell learn. You need a network. And so to do that, we set up the Center for Global Epilepsy. So that was launched officially last year, and the formal launch party only happened about 6-8 weeks ago now. And this is to build a network to try and link people who work in high-income settings with those who work who are in resource underprivileged settings to work together to try and drive mind-brain health forwards, again, using epilepsy as the example. So to conclude, epilepsy is only the exemplar. It's not to take away lots of things about epilepsy. It's just that these difficulties apply to many conditions in many settings. Equity, as we heard right at the start of this conference, is fundamental to driving meaningful change, and partnership is crucial. It is very true that you don't know what you don't know unless you ask and find out. So you have to be very inquiring. And all AI and tech in healthcare will need to be grounded in patient need and deliverable by clinical teams working together. And I thought I would leave you with two things. One, a quote from Taylor Swift, because it's always good to end with a quote from Taylor Swift. So she said, "I should not be left to my own devices. They come with prices and vices. I end up in crisis. Tale as old as time." If we pursue an agenda where you're really just driving things for self, you're not really pursuing an agenda at all. You have to work together, and that's the only way we will avert crises. And the other thing I thought I'd leave you with is this photo. As you can see, I'm very fond of photos, but I also think it's important that to see true partnership, it isn't always people from resource privileged settings going to resource underprivileged settings. You need to bring people together. So this is the whole team. This is the almost everyone who is part of the Global Epilepsy program being hosted in Oxford. And exactly as was said at the start of the conference, this led to lots of good collaborations, lots of novel ideas, and I very much hope that we can explore the same here. Thank you very much for your attention.
External validity of the data set, right? Which introduces bias, and also stigma seems to be a part of bias. That is the endogeny of the project. And the second part is the root cause seems unaffected by the research, which is we still don't have any additional neurologists in the space. So could you talk about the throughput of equity as a outcome in the way that you set up the experiment?
Thank you so much. So thank you for the kind comments and truly excellent questions. So the external validity, first of all, you're entirely right. We need to do more work on that and work out why there is these differences between the internal and external validation sets. And one of the things about epilepsy, it will apply similarly to the schizophrenia and the psychosis data. In very nuanced conditions, you do need large data sets. And I think all we really wanted to show in that paper is that don't just take an app from one location, put it in another location and say it's going to be fine, because actually you might create more risk. So if you take an app and you put it into a country that only has 2 neurologists, a lot of people might use that app and the app becomes the de facto neurologist. If that app isn't very good for that country, you can end up in a lot of trouble. So I think that you're quite right. There is much more work to do on that, and they're working out what the differences are that underpin the internal and external validation is going to be important. To your point about solving the fundamental problems about infrastructure, so first of all, I'd say we have to keep trying. We have to keep trying. And it does come. The more research and the more engagement there is, for a start, the more incentive there is for people to stay and help deliver that care. So Dr. Gift Ngwende, who's the Zimbabwean neurologist that was with me in that photo, so for many, many years, he was the only neurologist. And you have to be someone remarkable to be the only neurologist. But since we've started the partnership, now there are 2 other neurologists in Zimbabwe, and it's much easier to stay as a team of 3 and build that up rather than being a sole hand trying to drive the whole system. So I think that it will come, and I think that, again, the technology is not to replace any of the work that the neurologists or cardiologists or psychiatrists, whoever you're working with, are doing, but it's to streamline the pathway so you get the pathway better. And I think there is, and we always learn much more from working in places like Zimbabwe than we can teach. And so I think that, yeah, there is definite hope, and we'll get there.
So we have time probably for one more question. Right here.
I have a very related question. So I guess one is for clarification. I could see somebody saying, look, epilepsy is a disease. Isn't epilepsy the same everywhere? Why do we need the data that we're collecting to be contextualized? Why can't we just take this app and apply it everywhere?
So because even if the seizure, even if the underlying network disturbance is the same, the way someone may report the seizure and the way they describe their symptoms are different. And that applies across a lot of healthcare, but especially in these nuanced conditions where you don't have a clear marker. So let's say, for example, for diabetes, you can do a blood glucose and it's either high and you have diabetes, or it's not and you don't. And that could apply everywhere. But for the nuanced conditions, and mind-brain health has a lot of nuanced conditions, what do you recognize as being the harbinger of dementia as opposed to just normal for context? So that's where the difference really comes in. Thank you.
Okay, we are going to do one more question
Okay, sure.
from someone online.
The first
You can ask the question and then follow up.
one. Okay. So the first question says, if you would like to expand the model to other groups, would you retrain the model and validate with 2 different data sets, or retrain the validation set only and see how well the model performs?
Yeah, so it's a good question. And one of the things is that we don't want to create a situation where you have to just create a brand new massive data set in each location, because it takes a lot of time. So I think that what you would do is you take the current model and then do external validation on that training set locally. But to go back to the points that have already been made, you cannot escape the cultural contextualization bit. You can't escape that. So you have to make sure that the questions in your model, if you translate them into a new language, that they translate appropriately, that the meaning is the same, and so on and so forth.
The person who asked the question said thank you.
Okay, thank
So,
you.
Thank you, everyone, for a wonderful session. We'll see each other again at the breakout sessions.
Thank you very much.